So, so just before we start our topic, just a few discussion, a random discussion. So, how was the mock test? Did you realize that you need to work hard on some specific areas, or you all did well, really well in the mock test? Can we have feedback from anyone?
I was not able to register, so I am waiting for PDF test actually.
All right. So definitely the PDF will be shared, and you can just go ahead with it.
Yeah, I'll
The
try inshallah.
reason, yeah. So Sidra, are you the one who is giving in September?
No, I am for January inshallah.
All right. Inshallah, inshallah, definitely. And I can see Paris. Paris, did you attempted the mock test?
Yes, Dr. Aksa, I realize that revision is very important.
Yeah, exactly.
And I was so much depressed after giving.
No, no, it's just like to have you get motivation and take it as an encouragement for you. You know, you just need to revise the things. Once you'll just go through it, then you'll be able to revise it quickly than the first time
Yes,
you read it. Yeah, because your points will be highlighted. You will have written some important points in the corners. Try to take the print out of the guideline rather than in the laptop because it makes your eyes so much fatigue in the light. It's difficult.
okay.
Sapna, did you attempted the test? Especially for the September candidates, I'm really worried for all of them. Because for January we still have some time. But for September, we want you now to be more enthusiastic towards your studies. Now, no more
Yeah,
laziness.
actually, I attempted the test, but yeah, the as Paras said, it, I also couldn't complete it properly. Like there were multiple wrong answers. Uh, and I was planning for September, but I got a mail that this time I couldn't get in. It's postponed for 2021.
Okay, no worries. You know, January is not so far. Still, you have some time to go. You can have still some time. But especially for the September candidates, you know, they need to like boost up themselves now. A very less time is left because now the exam is turned into be an online one. Now you don't need no, you don't need to have to struggle for the visa purposes. You either you have to go to Karachi, Islamabad, or somewhere who is living anywhere in the country, in different countries. Now you don't have to go with this struggle. Now this is being over. They've just simplified it, making it easier. The RCOG is facilitating all the ways through to us to get through these exams and get the degree. Now we need to all put our efforts and make it done.
Actually, there were some five sets of questions, and I attempted one or two questions, and then somehow it got stuck, and then it showed me the result as 2 out of 40. I just did two questions, and the second, I couldn't understand how it worked. And actually, I could do only the third set properly, it seems.
Maybe the
There was
connectivity
some.
issue may be there, but definitely what we can do, we all mentors will decide a date, and we can come up to a date and discuss all the questions of the mock test on the live session. We can discuss this so that everyone can have any confusions are there. You can just clear up yourself. That is
Mhm.
why we just put only the SPAs were there. There was no EMQs in this mock test, just to motivate, you know, so that you're able to do it and get to the onto the right track from now onwards. Definitely,
Okay.
we'll do this. We'll consider this and make a live session for that very soon.
Okay. And once I tried to do it in my mobile, but it was not showing the full screen. Only half of the questions were visible. Um, in laptop it was okay, but I couldn't do that in the mobile. Only half of the questions were visible. I don't know whether it was the fault at my end. I don't know, but there was
Yeah.
some issues like that as well.
Yeah, maybe we can we'll just go through it. My IT, I'll inform my IT team about it, and definitely they will look into this matter as well.
Okay, ma'am.
Yeah, and Ahmed, as you're asking about the registration, yes, definitely I'll take into consideration. The IT team will inform you how to register about it and how you can go ahead with it. Excellent, Shilpa. A very claps for you that you really did 12, attempted 12 questions, and all of the questions were correct from your side. That's really appreciated. Very big claps for you. So yeah, let's begin with our today's lecture. We have finished our maternal medicine module. Almost it is done. And now we've started our oncology module. This is the second session of our oncology module. The first one was taken by Dr. Takwa, that is on cervical screening. And today we are going to discuss the ovarian masses, suspected ovarian masses in premenopausal, postmenopausal, neonates, and the adolescents. We are going to cover all of them together today. So just to begin with, it's a Green Top Guideline number 62, Management of Suspected Ovarian Masses in Premenopausal Women. So from the background and the introduction, up to 10% of the women will have some form of surgery during their lifetime for the presence of an ovarian mass. In premenopausal women, almost all of the ovarian mass and the cyst are benign. The overall incidence of a symptomatic ovarian cyst in a premenopausal female being malignant is approximately 1 in 1,000, increasing to 3 in 1,000 at the age of 50 years. We need to understand this point, as it has been a very clear-cut SPA in Andrew Caesar, Brian. You can find it all in all of the books. A very common question that the incidence of simple ovarian cyst symptomatic in the premenopausal female before the age of 50 years is 1 in 2,000, but when the woman reaches at the age of 50 years, the risk increases to 3 by 1,000 at the age of 50 years. We need to understand this point. And you also need to remember this point, as there are many frequent SBAs on this question. And among them, one of them is an exceptions, which are the germ cell tumors in which there is elevation of specific tumor markers such as alpha fetoprotein and beta HCG. And also, in germ cell tumors, we need to remember that there are elevation of 3 tumor markers in case of germ cell tumor. The first one is alpha fetoprotein, the other one is the beta HCG, and the third one is the lactate dehydrogenase. However, in the guideline, only 2 of them are mentioned, but through the strategy, we have found out that there's also elevation of the third protein tumor marker, that is lactate dehydrogenase. In 10% of the suspected ovarian masses, they are ultimately found to be non-ovarian in origin. It is important to consider the borderline ovarian tumors as a histological diagnosis when undertaking any surgery for ovarian masses, and when such a histological diagnosis is made or strongly suspected, referral to the gynae oncology unit is recommended. Whenever we are suspecting any of the tumors, irrespective whether it is endometrial, ovarian, cervical, whatever, we need to refer the patient to the gynae oncology unit. Now, in terms of preoperative diagnosis, sometimes can be difficult with radiological and serum markers being relatively insensitive, especially in their differentiation from stage 1 ovarian epithelial cancers. So, although up to 20% of the borderline ovarian tumors, they appear as simple cysts on the ultrasound, the majority of such tumors will have suspicious of ultrasonographic findings. So it is very important that we understand that not only the radiology, that the images will help us. Along with the images, we need to take help from the serum markers as well, because sometimes doing one investigation may not have such a good very sensitivity and a specificity. So we need to sometimes we need to do together in combination the investigations in terms of radiological as well as the serum markers. Now, mean survival time for women with ovarian malignancy is significantly improved when managed within a specialized gynecological oncology service. Hence, early diagnosis and referral is important. For any tumor, for any malignancy, it is very important that it should be diagnosed at an early stage, and once diagnosed, it should be referred to an appropriate place. That is the gynae oncology unit. And once it has been referred, then definitely once the treatment has been started at an early stage, then the survival time increases, survival rate increases for that person, for that lady, basically. Now, what we do mean in the preoperative assessment of women. Hope I am clear to you till these slides. Am I clear? Or you want me to repeat any point for you all?
Clear.
All right, thank you. So now in terms of preoperative assessment of women with ovarian masses, what is the role of the history examination in the assessment of women with suspected ovarian masses? A doctor who's there should take a thorough medical history, should be taken from the woman with a specific attention to risk factors or protective factors for ovarian malignancy and a family history of ovarian or breast cancer. Now, history is really very important because we should know the symptoms of the malignancy also. In the history, we are going to ask the symptoms of malignancy. Like symptoms of malignancy could be if the patient is having any abdominal distension, increase or decrease appetite, or she's having any pain in the pelvis or the abdominal region, having pressure symptoms in the form of increased urinary urgency, frequency. And we also need to check about the weight of the woman, whether the weight has decreased, because in the malignancy, when her appetite is reduced, usually the weight is decreased. And along with that, we also need to ask from her about whether she is using any form of contraception, because some of the contraceptions, they are protective. And also we need to know about the breastfeeding status, whether she is breastfeeding her baby, or we also need to ask from the woman about the history of hysterectomy, whether her uterus has been removed or not. Because these are some of the factors that we need to know from the history. And definitely, what is the importance of this family history of the ovarian or the breast cancer? We are going to discuss this in the postmenopausal GTG in the next few slides. So a careful physical examination of the woman is essential and should include abdominal, the vaginal examination, and the presence or absence of local lymphadenopathy. So in the physical examination, what are we looking for? We are going to look for the general look and also the BMI of the patient. We are going to look in terms of her anemia, whether she is anemic, any element of dehydration. We need to look at these. By physical examination, we mean this. And for the abdominal examination, we need to assess the mass, whether the mass is how much weeks is the size of the mass is, and if there is any associated, what is the extension of the mass, what is the features of the mass, basically we need to find out on per abdominal examination. And in the per vaginal examination, we need to assess for any tenderness is there, any nodularity, or any we can feel the bulge in the posterior fornix. We need to know these things. And along with this, we need to assess the lymph nodes also as well. Because with the lymph nodes, when we're going to discuss the malignancies, ovarian malignancy, then we need to see that the lymphadenopathy, if the lymphadenopathy is there, then some of the management is also changed. We are going to discuss this in a few next lectures. So in the acute presentation of pain, in the acute presentation with pain, the diagnosis of accident to the ovarian cyst should be considered, that is torsion, rupture, or hemorrhage. If any patient who comes with an acute pain or an acute abdomen with a diagnosis that has been nailed as an ovarian cyst, so we need to consider the differential diagnosis as ovarian torsion. There can be torsion, the cyst can twist on itself, or there can be rupture of the cyst, or sometimes because of the rupture there can be hemorrhage of the cyst, the bleeding inside the uterus, out in the abdominal cavity. We need to see this. So we need to keep this differential diagnosis in our mind whenever a woman comes with acute abdominal pain having an ovarian cyst. We need to keep these in mind. Now, what blood test should be performed? Serum CA-125 assay does not need to be undertaken in all premenopausal women when an ultrasonographic diagnosis of a simple ovarian cyst has been made. Can anyone explain me this point, please?
CA125 is not usually raised in benign cysts, not in premenopausal age.
Okay. Yeah.
And the,
Mm-hmm. Yes, exactly. Very right. So if a woman who is just let's take a suppose a scenario, a woman is there who is 35 years old. She's and she's having we are suspecting her as a case of having a simple ovarian cyst. So how should we diagnose that cyst? If we are not doing CA1 serum CA125, then what investigation should be done for her?
Ultrasonography.
ultrasound is more specific than CA125.
Yes, ultrasonography. Now, what type of ultrasound? Whether it is transabdominal or transvaginal?
Vaginal.
Yes, exactly. But if the woman is not sexually active, then
Transabdominal.
yeah. So you need to keep this mind. There's an EMQ on this question that there's a woman who's having a simple ovarian cyst. The first investigation in cases of premenopausal women is an ultrasonography. But when the woman is not sexually active, you have to do an ultrasound by transabdominal route. But if the woman is sexually active, you can do the ultrasound can be done for her by transvaginal route. You need to see this buzzword very clearly whether she is sexually active or not, because this word sexually or not sexually active can change your option. A very important point with relation to the EMQs. Am I clear this point to all of you?
Yes.
Thank you. Now, the lactate dehydrogenase alpha fetoprotein HCG should be measured in all women under the age of 40 years with a complex ovarian mass because of the possibility of the germ cell tumor. So now, I'll also be discussing, there was an SPA in one of the books. I most likely that I remember, it is from Andrew Caesar. There was a lady, she was having the age of 32 years. When ultrasound was done for her, the ultrasound features of having a complex ovarian mass. And she was having the likely diagnosis for her was as germ cell tumor. So what are the serum tumor markers you are going to do for that lady?
Lactose alpha fetoprotein
And
Beta
HCG.
yes, very important that in case of germ cell tumors, we are going to do alpha fetoprotein, beta HCG, lactate dehydrogenase. But if there isn't any now, if the question says the lady is same, she's having a complex ovarian mass, lady is at the age of the lady is 32 years, and she is having a diagnosis of granulosa cell tumor. So which tumor markers are going to be raised in her case?
estrogen should be checked.
Along with the estrogen and
Inhibin.
Excellent. Who is this?
Dr. Chanda.
Yes, Dr. Chandra, very good, very clap for you. Excellent. You have told us a very good point that in case of granulosa cell tumor, there will be increase in the levels of estradiol and as well as inhibin. My third question, no worries. My third question from you is, if a patient, she has been diagnosed with a case of epithelial ovarian cancer, so which tumor marker is going to be raised?
Serum CA125.
CA125.
Yes, exactly. Excellent. Excellent, Twinkle, Sapna, all of you. Yeah, all of you are correct. Paris, thank you so much. You all are doing really very well. So I'll just repeat this point one again. In case of germ cell tumors, 3 tumor markers are going to be raised. We can remember it like 3, 2, 1. In case of germ cell, they are going to be raised in the levels of alpha fetoprotein, beta HCG, lactate dehydrogenase. Now, in case of granulosa cell tumor, there's going to be increase in the level of two hormones, two serum tumor markers, that is estradiol and inhibin. When it comes to epithelial ovarian cancer, there's going to be raised in one, that is serum CA125. So 1, 2, 3, or you can remember it 3, 2, 1, whatever is convenient for all of you. So now CA125 is unreliable in differentiating benign from the malignant ovarian masses in premenopausal women because of the increased rate of false positive and reduced specificity. So that means CA125 is not a serum marker that is going to differentiate between benign or malignant because it has a high rate of having false positive and reduced specificity. So it's not a reliable tumor marker. However, CA125 can be raised in many frequent conditions that we are going to discuss in the next few slides. Only you just need to remember this point that it's important to note that CA125 is primarily a marker for epithelial ovarian carcinoma and it is only raised in 50% of the early stages disease. The word 50% is really very important. It is not raised in all cases of epithelial ovarian carcinoma. It is just raised in only 50% of the early stage disease. Am I clear for you? For
Yes.
all of you? Thank you.
Yes.
Now, when the serum CA125 assay is not necessary, when a clear ultrasonographic diagnosis of a simple ovarian cyst has been made. So when a simple ovarian cyst has been diagnosed by ultrasound, we don't need to do further investigations via doing serum CA125. If her age is less than, if there's a complex ovarian mass, and if her age is less than 40 years, then we are going to do 3 tumor markers, that is alpha fetoprotein, beta HCG, and LDH. But if the serum CA125 is raised and it is less than 200 units per ml, further investigations may be appropriate to exclude and treat the common differential diagnosis. Now, in the next few slides, I'm going to tell you that what is the cutoff CA125 that we are going to deal with. When serum CA125 levels are raised, serial monitoring of CA125 may be helpful as rapidly rising levels are more likely to be associated with malignancy than high levels which remain static. If the level of serum CA125 is more than 200 units, discussion with the gynae oncologist is recommended. Guidelines from United Kingdom and the United States of America recommend that alpha fetoprotein and beta HCG should be measured in all women under 40 years with a complex ovarian mass because of the possibility of germ cell tumor. This point we have already discussed. Just to tell you the clarification of CA125, what is the cut point that I'm going to discuss in next few slides to make it clear and easy understandable for all of you. Now, in terms of imaging, what is the role of ultrasound in the assessment of suspected ovarian masses? A pelvic ultrasound is the single most effective way of evaluating an ovarian mass, with transvaginal ultrasonography being preferable due to its increased sensitivity over transabdominal. In some cases, a combination of transvaginal and a transabdominal route may be appropriate for the assessment of larger masses and extra ovarian disease. So we already discussed this point that once we are going to do the investigation, ultrasound is the first line of investigation for women with premenopausal ovarian cysts, and ultrasound by transvaginal route will be more appropriate because of its increased sensitivity. However, other types of scan, that is color flow Doppler, 3D images, all of them, they have no role to improve the diagnostic criteria for or the diagnostic accuracy of the cyst. So only the first investigation that we are going to do is a transvaginal ultrasonography. The use of color flow Doppler has generally not been shown to significantly improve the diagnostic accuracy, but the combined use of the transvaginal route in combination with color flow mapping and 3D imaging may improve the sensitivity, particularly in cases of complex cases. So the first line will always be ultrasound, that is transvaginal ultrasound. And then we are going to do, in cases of complex cyst, we may need to take the help by the use of color flow Doppler as well. But always the first line investigation will be transvaginal ultrasonography because of its increased sensitivity. Now, what is the best way to estimate the risk of malignancy? So an estimation of the risk of malignancy is essential in the assessment of an ovarian mass. At present, the risk of malignancy index is the most widely used model, but recent studies have shown a specific model of ultrasound parameters, the ultrasound rules, derived from the International Ovarian Tumor Analysis, that is IOTA, we call it as IOTA, to have increased in sensitivity and the specificity. The routine use of CA-125 assay in the investigations of premenopausal women with an ovarian mass has not been shown to be useful because of its relatively poor specificity. So we've already discussed this point that CA-125 is not the first line investigation in case of premenopausal women. I'm repeating this point again and again because it is a very important part that you will understand when you're going to solve the EMQs with me in the next, at the end of the session, that CA-125 is not the first line investigation in cases of premenopausal women. Now, in order to assess the risk of malignancy, we can do the risk of assessment of malignancy. We have a score that we call as a risk of malignancy index, and the other one is an IOTA. Now, how do we use this risk of malignancy index? There are 4 types of risk of malignancy index, that is RMI 1, 2, 3, and 4. But till now, only RMI 1 and RMI 2 has been used validated. They have been used validatively. Now, how to diagnose, how to use this RMI score? We are going to do it now. A systemic review of diagnostic studies concluded that RMI-1 was the most effective for women with suspected ovarian malignancy. The NICE guideline on ovarian cancer recommends that for women with a suspected ovarian malignancy, the RMI score should be calculated and is used to guide the woman's management. So it is the one which is going to guide us the future management. I can see from the questions. Nikita, can we have you? Can you unmute yourself and please ask your question? CA-125 more than 200 or RMI?
No, 2 slides before you said we need to refer the patient to an oncologist, oncologist. If it's more than 200, it is risk malignancy index or CA-125. You said CA-125. I thought it's risk malignancy index. If it's more than 200, we'll be referring.
Yes, it is. It is. When we are going to read when in the next few sessions, we are going to do the guidelines on NICE guideline. Then you are going to see when the CA-125 is even raised, we are referring to the patients to the gynae oncology. And when the RMI is also more than 200, we do refer the patient that we are going to discuss the flow chart. That is, there is a whole flow chart that we are going to discuss at the end of this.
Okay, thank you.
Ma'am, I have a question.
Yes,
if CA-125 is raising, then how frequently we should check that CA-125?
Excellent question. I really love your question. Definitely. I'll be answering your question in next few slides.
Okay,
Is it okay with you?
Okay.
Thank you. Yeah. So till now, the only validated score that we are using is the RMI-1, that is risk of malignancy index 1, and the other one is the IOTA. Now, just one more thing to understand, that in cases of pre-malignancy, that is in premenopausal, the most widely used, although it is the RMI, but IOTA is mostly used in cases of premenopausal. However, when we talk about the postmenopausal cyst that we are going to talk, then that there comes the role of risk of malignancy index. Now, how do we calculate this RMI? RMI, that is risk of malignancy index. It is a combination of three pre-surgical features, that is serum CA125, menopausal status, and the ultrasound score. So I want you to have, please all of you take a pencil and a piece of paper in your hand, because I'll be giving you some of the questions to calculate the RMI for me now, so that you can understand how to do this. Because in the exam, you have questions in which you have to calculate the RMI. So ready, all of you?
Yes, ma'am.
All right, great. So first we need to understand that how do we calculate RMI? That is the risk of malignancy index. U stands for the ultrasound score. M stands for the menopausal status, whether she is premenopausal or postmenopausal, and the value of CA125. So now what does the ultrasound? U stands for ultrasound. So what are the features of the ultrasound? So the ultrasound score is scored as 1 point for each of the following characteristics. That is multilocular cyst, metastasis, solid areas, ascites, and bilateral lesions. If in the ultrasound, if you find all of these five findings, that is multilocular cyst, metastasis, ascites, bilateral lesions, and solid areas. If you find all of these, then the score will be 3. If you don't find any of the features out of this 5, then the score will be 0. If you find any one out of the 5 features, if you find only one of them is there, then the score will be 1. But if the feature is between 2 to 5, then the score will be 3. Remember, when the ultrasound features is between 2 to 5, your score for ultrasound will be 3. I'm again repeating this point. For the ultrasound features, there are 5 points we need to look for. How can we remember this 5 points? What I used to do it to remember, still I do it like this. M2 BAS, that is metastasis, multilocular cyst, bilateral lesions, ascites, and solid areas. M2 BAS. M2 SBA. You can also make it like this, M2 SBA, to just remember it. M2 means there are going to be 2 M. That is, one is for metastasis and the other one M is for the multilocular cyst. And S stands for solid areas, B stands for bilateral lesions, A stands for ascites. If there is no feature on the ultrasound, it's going to be 0. If only one feature is there, then the score will be 1. If the features are in between 2 to 5, then your score will be 3. Am I clear till here so far?
Yes, ma'am.
Thank you. Now, coming to the M, that is the menopausal status. If the woman is premenopausal, the score will be 1. If the woman is postmenopausal, the score will be 3. Remember, if the woman is premenopausal, the score will be 1. If the woman is postmenopausal, the score will be 3. Now, how do we define postmenopausal? Postmenopausal is a woman who has no periods for more than 1 year, or a woman over the age of 50 years who had an hysterectomy done. And now, the last feature of the RMI index is the CA125. CA125 can be any value from 0 to hundreds or even thousands of units. That is, CA125 is always going to be in the units of international unit per ml. So just a question, please calculate. I'm telling you a question. You need to calculate the RMI score for a patient. There's a lady who is 45 years old. She is having severe abdominal pain, and she came into the emergency department where an emergency ultrasound was done for her, in which he found ultrasound features of ultrasound was showing a cyst of 5 into 10 centimeter, which is multilocular, which was having solid areas, and it was bilateral. and after that, a blood test was done for her that was showing an CA125 level of 15 international unit per ml. So what is going to be the RMI score for this lady?
75. Sorry, 45. 45. Sorry, 45.
Okay. So
Ma'am,
can you
she is
explain me how?
45. She is premenopausal, that is
45.
one, and she is having multilocular cyst, solid areas, and it's bilateral. It's a 3, and 2 to 3 we have score for 3, and CA1 to 5 is 15. So she is having RMI of 45.
Yes, exactly. Excellent. Yes. So in the same way, in the exam also you are going to have all the values will be given to you and you will have to calculate the RMI score.
Dr. Aksa, if
Yes.
CA125 is not our first line investigation, then why we added in RMI in premenopausal ladies CA125?
Look, we have this
That
is
is
Paris
for
here, na? Am I right?
Yes,
This is Paris?
yes, yes, yes.
Yes. Okay. Yes, Paris, exactly. Your question is very valid. Look, we have two ways in which we can calculate. One of them is the RMI index, the other one is the IOTA. RMI index, that is the risk of malignancy index, it is basically for the postmenopausal woman. And the IOTA is for the premenopausal women. That is why in the menopausal status, you can see it has given both the options. It can either be premenopausal or postmenopausal. Both of them is there. And CA125 is not given as the first line in the CA125 is the first line investigation in cases of postmenopausal women. This I'm going to discuss in the next TTG that we are going to discuss. That is why the RMI index is more important in cases of postmenopausal women to be calculated. Am I clear for you, Paris, so far?
Okay, doctor.
Thank you. Thank you, Sapna, Shaista, Nikita, Sonia, every one of you. All of you are correct. And you're learning expertise, becoming expertise to calculate the RMI.
2 minutes.
So, a recent systemic review showed that the pool sensitivities and specificities of an RMI score of 200 in the detection of ovarian malignancy, the sensitivity of RMI 1 is 78%, the specificity is 87%. Now, the RMI, it has a sensitivity
Ma'am, I
RMI
think
1.
so you have missed a slide.
Let's check it. This one?
Yes, ma'am.
Okay. Okay, this side we have gone through it, but I'll definitely go it again for you. Which RMI should be used? That is, to date, only RMI 1 and RMI 2, they have been sufficiently validated. There are 4 types of RMI, that is 1, 2, 3, and 4. But till date, we are using RMI 1 and RMI 2. The NICE guideline of ovarian cancer recommends that for women with suspected ovarian malignancy, the RMI 1 score should be calculated and it is used to guide the woman's management. When we are going to study the guideline or NICE guideline of ovarian malignancy, then we are going to see that how RMI scores with the management, how does it comes into effective. All right.
Ma'am, in the previous slide, you told that IOTA is more sensitive and specific than RMI, and here we say that RMI is better. Is there a contradiction?
No, there's nothing said like that. It's better. It says that only RMI 1 and RMI 2, they have been sufficiently validated. That means it is valid till now. It is being used. RMI score, definitely. It's one of the risk of malignancy index that we are going to calculate in all women of postmenopausal women. And IOTA, it is specifically or mostly used in cases of premenopausal women.
Okay.
Just to
So
clear
my
yourself,
question
yeah,
is,
yeah, just to clear
um,
yourself, make it easier so that you don't have any confusions in your mind. Okay. Yeah, yes, please
okay.
go ahead with your question. Yeah.
So for postmenopausal, it is RMI, and for premenopausal, it is IOTA. Is it like that?
Yeah. When we are going to solve the EMQs, yes. In terms of EMQs, in terms of SPA, you are going to solve it and you will find it like this. In the buzzwords, when you are going to solve it, you will find the buzzwords there. And when you're going to read it, you will just directly go to the option and you will mark the correct option. Okay.
Okay, ma'am. Okay, ma'am.
So we've already learned how to calculate the RMI. So the specificity and the sensitivity of RMI1, that is the sensitivity of RMI1 is 78% and the specificity is 87%. Now, is there any other way to estimate accurately a risk of malignancy in premenopausal women without using CA125? So that comes from the simple ultrasound rules derived from the IOTA group. The use of specific ultrasound morphological findings without CA125 has been shown to have high sensitivity, specificity, and the likelihood ratios. If not clear, classifiable from these routes, further investigations by a specialist in gynae ultrasound is appropriate. Now, what do I mean by IOTA group? That I'm going to tell you. Now, IOTA, it is divided into B rules. By B, I mean to say benign. By M rules, I mean malignancy. Now, what are the 5 points that come in benign? That it should be a unilocular cyst, having presence of solid components where the largest solid component is less than 7 millimeter. There can be presence of acoustic shadowing, smooth, multilocular tumor with a largest diameter of less than 100 millimeter, and there will be no blood flow. I would highly appreciate if all of you can mute yourself because it disturbs me as well. And whenever you are listening to the recording, it is difficult for everyone to understand the recordings as well. So it would be highly appreciated if you can do that for me. If you have any questions, you are most welcome. You can ask at any point of time. But when you have no any questions, I will highly appreciate if you just mute yourself. Thank you for that, everyone. So IOTA, it is divided into 2 types. That is the B. B means by B, I mean benign. By M rules, I mean malignant. In terms of B rules, there are 5 points that we need to remember. It is going to be a unilocular cyst. It can have presence of solid components where the largest solid component will be less than 7 millimeter. There can be presence of acoustic shadowing, a smooth multilocular tumor with the largest diameter of less than 100 millimeter. There will be no blood flow in cases of B rules. Now coming to the M rules, that is the malignant rules. This will be on the ultrasound, you're going to find the features of having irregular solid tumor. There can be ascites, at least 4 papillary structures. The word at least 4 papillary structures. There's going to be irregular multilocular solid tumor with the largest diameter of 100 or more than 100 millimeter. Please remember this point. In case of B rules, it is going to be less than 100 millimeters. If it is 100 or more than 100, it is going to be M rules. And blood flow, there will be a strong blood flow. Now, when we did an ultrasound, we find that the woman is having M rules, any of the out of 5, if she is having any 1, 2, 3, 4, or 5, she will be referred to the gynae oncology service. Remember this point, irrespective of whatever the management option is going to be there, you need to choose that this patient with M rules, she will only be referred to the gynae oncology service. Am I clear? This point, please make sure you are all clear for this point.
Ma'am, I have a question. In B role, presence of acoustic shadowing. What does it meaning?
When we do an ultrasound, you can see the shadows are formed. You can see the hypoequic areas, that is dull to the normal tissue, or hyperequic. That means that they are more they're having more light than the normal tissue, surrounding normal tissue. That is what we call as acoustic shadowing. But that is
Okay.
not going to be our job. The ultrasound report will tell you whether there is presence of acoustic shadowing. Is there in the report? It is going to be mentioned.
Okay, ma'am. Thank
Okay.
you.
So can you
Okay.
repeat the rules for me without having a look at this? The B rules.
Cumulacular
Ma'am.
cyst,
Hmm.
presence of solid component, and the size of solid component should be less than 7 millimeter if it is present, and there may be presence of acoustic shadowing and smooth multilocular tumor, the largest diameter of which is less than 100 millimeter or 10 centimeter, and there
Yes.
is no blood flow in color Doppler.
Excellent. Excellent. And please, if you could mind, could you repeat the M rules also for us?
Yes, ma'am. In MROs, the tumor will be solid and irregular filling. There will be ascites, and at least there must have 4 papillary structure within the tumor, and irregular multilocular solid tumor with large diameter should be more than 10 centimeter or more than 100 millimeter, and there will be more strong blood flow within the tumor tissue within the septa in Doppler, USG Doppler, color Doppler.
Yes. Excellent. I'll just clear one point in the M rules. That will be irregular multilocular solid tumor with the largest diameter of 100 millimeter or more than 100. It can be 100 or 10 centimeter or more than 10 centimeter. Both can be there. 10
Oh,
or
yeah.
more than 10, 100 or more than 100 millimeter.
Yes, ma'am. I have
Okay.
mistake.
And if yeah, no problem. Just to now you'll remember it for your lifetime. You will remember it till you go into the exam hall. I'm sure
Okay,
you remember it. And when any of the M rules is found, what you will do with the patient in the terms of management?
Gynecological oncology.
Service, yes. You are going to refer the patient to the gynae oncology service. Excellent.
Ma'am, do you have any mnemonics for this one?
No, dear, I just remember. Yeah, I wish I could make it one for you. But definitely, because till now even I've just learned it by this way. Now, management. Now we are coming to the management. Management of ovarian masses presumed to be benign in non-emergency situations can an asymptomatic woman with simple ovarian cysts be managed expectantly. Now, with a small woman with a small, that is less than 50 millimeter diameter or 5 centimeter simple ovarian cysts, they generally do not require follow-up. As these cysts, they are likely to be physiological and almost they resolve within 3 menstrual cycles. Women with a simple ovarian cyst of between 50 to 7 millimeter or that is 5 to 7 centimeter in diameter, they will be followed up by doing an yearly ultrasound, and those with a larger cyst that is more than 70 millimeter or 7 centimeter, they will be considered for further imaging or surgical intervention depending on the individualized patient. So I'll repeat this point once again. If we have a simple cyst which is measuring less than 50 millimeter in diameter or less than 5 centimeter in diameter, this cyst does not require any follow-up. It is likely to be a physiological one and it is going to resolve in 3 menstrual cycles. But if the simple ovarian cyst is in between 50 to 70 millimeter in diameter or 5 to 7 centimeter in diameter, we need to do the follow-up by doing a yearly ultrasound. 1 yearly ultrasound will be done for her. But if the cyst is in diameter, it is more than 70 millimeter or more than 7 centimeter, either further imaging will be done for her in the form of MRI or we need to do surgical intervention. So there are 3 points: less than 50, 50 to 70, and more than 70. Less than 50, there is no need for follow-up. 50 to 70, just once. And more than 70, you need to do certain intervention, either do treatment or imaging. Hope I'm clear to all of you this much.
Yes.
Now, how should persistent asymptomatic ovarian cyst be managed? Ovarian cysts that persist or increase in size, they're unlikely to be functional and may warrant surgical management. Now, any size which either remains same in the size or it increases, this is not going to be a functional cyst, and we need to treat that cyst by doing any surgical intervention. Ovarian cysts that persist or increase in size after several cycles are unlikely to be functional. Mature cystic teratomas, that is dermoid cysts, have been shown to grow over time, increasing the risk of pain and ovarian accidents. So surgical management is therefore usually appropriate with preoperative assessment using either RMI or ultrasound rules by IOTA group. Now, does the use of combined OCP pills help in the treatment of functional ovarian cysts? No, it does not promote the resolution of functional ovarian cyst. You need to remember this. OCPs, they have no role in resolution of the functional ovarian cyst. Okay. Now, is the laparoscopy? Yes, please. Yes, please.
Ma'am, this slide. Ma'am, in this slide, the persistent asymptomatic ovarian cyst, irrespective of the size, we do treatment, or otherwise, if the cyst is less than 5 centimeter and persistent and do not resolve, then we have to give treatment.
Sorry, could you please repeat your question? There's a lot of interruption on your side. I could echo my voice. I could hear my own echo.
Sorry, ma'am. If the patient is having a cyst of less than 5 centimeter, this is persistent and patient is asymptomatic. Then do we need to treat this cyst as well surgically? Less than 5 centimeter.
Less than 5 centimeter, but it is persisting, you are saying?
Yes, persistent asymptomatic.
Asymptomatic. If it is less than 5 centimeter and it is persisting, then you don't need to do any follow-up. Why? I'm going to discuss this in the next flow chart. So now, is the laparoscopic approach better for the elective surgical management of ovarian masses? The laparoscopic approach for the elective surgical management of ovarian masses has the following benefits. But if there is a large mass with solid components like having a large dermoid cyst, then laparotomy may be needed according to the need of the patient. Now, what are the benefits of laparoscopy when we are doing a simple cyst? That is, it will reduce the morbidity, febrile morbidity, patient will have less post-operative pain, lower rates of post-operative complications, patient can be discharged earlier from the hospital, reducing the burden of the hospital, and as well as the lower overall cost for the patient as well as for the hospital as well. So we need to remember these 5 benefits of laparoscopy. In all the cases of laparoscopy, when we are going to study the laparoscopy guideline also, in this also these are the same benefits that we need to remember. That is, it will reduce the morbidity, there will be less pain, less complications, less post-operative complications. Patient can be discharged earlier from the hospital, and it is cost effective for the patient as well as for the hospital as well. So just 5 benefits: less febrile morbidity, less pain in the post-operative period, less complications in the post-operative period, early discharge from the hospital, and less of a cost effective. It is more cost effective. Now, who should perform the laparoscopic surgery for a presumed benign ovarian cyst? So it will be performed, the laparoscopic management of a presumed benign ovarian cyst. It should be undertaken by a surgeon with suitable experience and appropriate equipment whenever local facilities permit. Now, the surgical management of ovarian masses, it depends on the several factors, that is the woman, including what is the suitability for her laparoscopy and what is the wish of the woman. That also needs to be respected. Now, in terms of the mass, that is the ovarian cyst, what is the size of this cyst, whether it is simple or complex, and what is the nature of the cyst, whether it is benign or malignant, and the setting that where she has come, whether it includes the surgeon skills are there, the equipment are present there to go for the laparoscopic surgery, because it's a very delicate surgery. So we need to consider three factors. One is for the woman, the other is for the mass, and the third one is for the setting, that is the place where we are working. We need to consider all three factors when dealing with the surgical management. Now, a decision should be made after careful clinical assessment and counseling considering the above factors. Should an ovarian cyst be aspirated? Aspiration of ovarian cyst, either vaginally or laparoscopic, it is less effective and it is associated with a high rate of recurrence. So never should be a cyst ovarian should be aspirated, because it has a very high recurrence rate, that is from 53% to 84%. So never we should aspirate a cyst, ovarian cyst, because the recurrence rate is high, that is from 53% to 84%. That is why we should never ever aspirate an ovarian cyst. Now, is it important to avoid an unplanned rupture of the cyst? Yes, definitely it is important. Why? The spillage of the cyst contents should be avoided where possible, because as preoperative and intraoperative assessment cannot absolutely preclude the malignancy. Consideration should be given to the use of a tissue bag to avoid peritoneal spills of the cystic content, bearing in mind that the likely preoperative diagnosis. It is preferable to avoid spillage of the cyst contents, because the apparently looking benign cyst characteristics of a cyst on preoperative and intraoperative assessment cannot absolutely preclude malignancy. And if a dermoid cyst gets spill out, there is a chance of having a chemical peritonitis that happens in around less than 0.2% of the cases. Ideally, the spillage should be avoided, because if we are doing the ultrasound or any investigations, we find that the cyst is benign. But intraoperatively, we found out that the cyst comes out to be malignant. That is why the content of the cyst should not be spilled in the cavity. Because if it is going to be spilled in cases of dermoid cyst, there's a risk of having chemical peritonitis that is less than 0.2%. But if accidentally there occurs the spillage, now what to do? If an inadvertent spillage does occur, there could be meticulous peritoneal lavage of the peritoneal cavity. It should be performed using large amount of warm fluid. Now remember, the warm fluid should be used. Now the use of cold irrigation fluid may not only cause hypothermia, but will also make contents more challenging by solidifying the fat-rich contents. Any solid content should be removed by using an appropriate bag. So we should remember that if any spillage occurs, we need to lavage the peritoneal cavity by using large amount of warm fluid. Why not the cold fluid? Because it will cause hypothermia, and also it will make the fat content of the content, it will solidify it. So it will be very difficult to remove from the peritoneal cavity. If any solid content, it should be removed using an appropriate bag. Now, when should an oophorectomy be performed? The possibility of removing an ovary should be discussed with the woman preoperatively. The pros and cons of electively removing an ovary should be discussed, taking into consideration the woman's preference and the specific clinical scenario. Because removing an ovary has its own hazards, has its own benefit as well. So we need to discuss both with the patient, and according to her wish, that will be done. Now, in terms of benefit, what is going to be the benefit? That when we remove the ovary, definitely she will land up in having a surgical menopause, and once she land up into surgical menopause, she can have bone problems with the heart, all the menopausal symptoms like mood swings, hot flushes, night sweats, all will be there. So for that, again, we'll have to start on the treatment of hormonal replacement therapy. That is when another story begins from there. But if we remove the ovary, yes, There will be decrease in the risk of ovarian cancer. But in all the population, there is a generalized risk of ovarian cancer. Definitely, this will be discussed in the NICE guideline. I'm not going to discuss this point now. Now, how should an ovarian mass be removed? Where possible, the removal of benign ovarian mass should be via the umbilical port. Please remember this point. The umbilical port is the point in the laparoscopy that the cyst should be removed. Why? Because it will cause less post-operative pain and a quick retrieval time than when using the lateral ports of the same size, and along with that, avoidance of extending accessory ports is beneficial in reducing pain, reducing the incidence of incisional hernia, and the incidence of epigastric vessel injury. It also leads to improved cosmesis. So you need to remember this point, that whenever the laparoscopy will be done, the port will only, that is the good port or the benefited port, the port that has more advantage is going to be the umbilical port. Why not the any other port? Because it can cause incisional hernia, it can cause damage to the epigastric vessels, which can lead to severe hemorrhage. So you need to remember this point. Whenever there is going to be injury to the secondary port, the vessel which can be damaged is the epigastric vessel. Remember my words, whenever in the secondary port there is going to be any injury, the damage to the nerve, damage to the vessel that is going to be damaged is the epigastric vessel. This is a very important SBA in case of secondary port. The vessel that is damaged is the epigastric vessel, and the port that is used is the umbilical port. Am I clear so far?
Yes.
Yes,
Thank
ma'am.
you. Okay. Yeah. So we have completed this. We have completed this premenopausal guideline. I'll just quickly revise few of the points which are very important. So first of all, the premenopausal cysts, they are very common, and usually most of them, they are benign. The chances of being the premenopausal ovarian cyst to be turn into malignancy is 1 in 2000, but at the age of 50 years, the risk becomes 3 in 1000. Remember this point, from 1 to it becomes 3 in 1000 at the age of 50 years. There's a clear-cut BCQ from Andrew Caesar on this. You cannot leave any marks on just simple questions, these simple questions. There's no excuse for all these simple questions at least. We have, in terms of, if we have germ cell tumor, then the tumor markers that are going to be raised is going to be alpha fetoprotein, beta HCG, and the third one is going to be LDH. If it's going to be a granular cell tumor, there will be increase in 2 tumor markers, that is estradiol and inhibin. In case of epithelial ovarian cancer, there will be raised in 1 tumor marker, that is CA125. 3, 2, 1. Now, we need to, whenever a woman comes with a premenopausal cyst, we need to take the history, and after taking the history, we are going to do the investigation. The first line investigation that we are going to do in case of premenopausal ovarian cyst is the ultrasound by transvaginal route, is the first line of investigation that is need to be done. Along with that, supportive can be done like in the form of transabdominal, but the first line investigation will always be transvaginal ultrasound. We have 2 scores, we have 2 ways to calculate the assess the malignancy, the risk of malignancy. That is, one is the risk of malignancy index, which has 3 features, that is ultrasound features, menopausal status, and CA125. The other one, we have the IOTA group, which has ultrasound features, B rules, and the M rules. Now, whenever the cyst is found, we need to manage the cyst according to the size. If the simple ovarian cyst is measuring less than 50 millimeter in diameter or less than 5 centimeter in diameter, this cyst needs only no follow-up. This cyst needs no follow-up. Remember my words, no follow-up. But if the cyst is measuring 5 to 7 centimeter in size, the follow-up will be 1 yearly by doing an ultrasound. If the size of the cyst is more than 7 centimeter, we need to do certain intervention, either in the form of surgery or in the form of investigations. Any one has to be done for the patient. Another one point that was really very important, that OCPs does not cause the resolution of the functional ovarian cyst. In terms of laparoscopy, for the removal of the ovarian cyst, laparoscopy is the best approach. In laparoscopy, the surgery should be done by the umbilical port because it is very effective. It will cause less post-operative pain quicker. The surgery will be done quicker and less incidence of having incisional hernia, and there will be no injury to the epigastric vessel. And why the laparoscopic approach is better? Because it will reduce post-operative morbidity, early recovery for the patient, cost-effective for the patient, and earlier discharge from the hospital. But however, if the cyst is large with solid components or it is a complex cyst, then laparotomy may be needed. Am I clear for all of you so far?